Hello, and welcome to your discussion on cardiomyopathy and heart transplantation. So cardiomyopathy, we'll start there. What that is, it's a disease of the heart muscle. It leads to weak and an inefficient heart muscle. This is often caused by genetics or CAD, stress, some medications, and viruses. There are many different types of cardiomyopathy, which we'll discuss, and the patho is going to vary per type. Ultimately, any of these types of cardiomyopathy may lead to low cardiac output, heart failure, arrhythmias, and sometimes sudden cardiac death. All of these cardiomyopathies, they progress at different paces per condition or individual factors. So we'll kind of look at them one by one. So the first cardiomyopathy is dilated cardiomyopathy, and you can see the picture here on the left. It shows a large, floppy, weak ventricle. So these large, floppy, weak ventricles can't pump efficiently. You see these large, weakened, particularly left ventricle. This will impair our systolic function, and that causes a difficulty in pumping blood out to the system. This can lead to heart failure, arrhythmias, and embolisms. Now, a certain type, the most common type actually of cardiomyopathy is ischemic cardiomyopathy. You will see this often in clinical practice. And what this is, it's caused by coronary artery disease and MIs. They create this situation where there's a lack of blood supply to the heart, and the heart muscle then can't pump well because of the damage from this lack of blood supply due to these narrow coronary arteries. So this will result in a weak heart muscle. This is, again, the most common type, and it's the leading cause of systolic heart failure in the world. So hypertrophic cardiomyopathy, you can see here in the picture, this thickening of the heart muscle. You can see it very clearly with the intraventricular septum and the ventricles. They're all hypertrophied. And this creates a situation where the chambers can't fill properly during diastole due to all of this hypertrophy. So there's no room in this heart to relax and fill. So this type of cardiomyopathy leads to diastolic dysfunction. It's often a hereditary condition, and it can lead to sudden cardiac death, especially we see this in athletes. Restrictive cardiomyopathy, you can see in the picture here, this is a rare condition, and this leads to stiff heart muscles that resist stretching. So these stiff ventricles, they don't expand well, and this will limit the heart's capacity to expand and fill, particularly during diastole. So it's, again, a diastolic dysfunction. It's often idiopathic, and it can be linked to some systemic conditions. Takotsubo cardiomyopathy, you can see here in the picture. This is a unique type of cardiomyopathy, so it's a little bit of a separate class, but it's still listed as a cardiomyopathy. This is a temporary cardiomyopathy, or it's transient, meaning it only lasts for a period of time. If the patient can get through this cardiomyopathy period or time frame, then they'll generally be back to normal in 4 to 6 weeks after it happens. So what happens here is we also call this broken heart syndrome or stress-induced cardiomyopathy because it is induced by stress. These patients are often women, sometimes men, but often women that are older than 55 to 60. And a lot of times it happens after they lose their spouse or something big happens to them. Maybe they lost all of their money, or there was a hurricane and it took everything they had. So it's a big amount of stress, which causes a release of catecholamines, particularly adrenaline, and this adrenaline surge will stun the heart muscle. You can see in the picture here that the left ventricle changes shape and enlarges for this period of time while they're under this amount of stress. And this stress will stun that actual ventricle. So patients come in often and it looks like they're having acute coronary syndrome. They'll have crushing chest pain. Their troponins will be high. Their CKMB, if they are measured, will also be high, and their ST elevation will be present in many leads. So it's a confusing clinical picture. So what often happens is we'll take these patients to cath lab, or we were thinking door to balloon time 90 minutes because we're like, this could be an MI. We get them down to PCI, they start the cath, and we see that their cath is clean. So like no coronary artery disease, no plaque or thrombus is causing this condition for them. So these patients can usually be okay after some time if they don't pass away from dysrhythmias during this event. So like if we can keep them stable during this period of time, again, they'll usually recover to their baseline function 4 to 6 weeks after. Some general clinical manifestations. They're going to be specific to certain types, but generally they all they overlap each other, and I wouldn't really memorize, each condition with each manifestation and each different medication. Just kind of look at them from a global perspective. Most of these patients will have angina, so chest pain, dizziness, palpitations, dyspnea. These patients that have cardiomyopathy will often be without symptoms for a long time, except for that transient cardiomyopathy, which is abrupt and comes on and leaves. But often the patients with cardiomyopathy, we see the disease progress different stages for them, like slow onset, and then when they have symptoms, we'll see them. We may see heart failure symptoms, which is often the common first symptom that we'll see in these patients. So, shortness of breath, JVD, hepatomegaly, edema. We may hear some murmurs on diastole or systole, depending on, their cardiomyopathy. We can hear an S3 or an S4. We can hear crackles in their lungs. Other symptoms we think about: insomnia, syncope, anorexia. And when we're diagnosing this, we look at an EKG, we're checking for dysrhythmias, very common in cardiomyopathy. A chest x-ray will show enlarged heart and presence of fluid in the lungs. An echocardiogram, we're looking at their left ventricular ejection fraction. Remember, normal is 55 to 65%. Less than 45% is going to indicate weak pump strength. So we start to think, they're having some heart failure at this point. Less than 30% ejection fraction represents a severe decrease in cardiac function and puts the patient at risk for increased risk of sudden cardiac death. So these patients will need an ICD, like we talked about before. The echo will also look at the structure and function of the heart. It will detect abnormalities. We can look at a cardiac MRI, which is helpful in the diagnosis of some types. And blood tests, of course, will look at the BNP because we're looking for fluid volume overload. How to manage cardiomyopathy is tricky. First, we're going to look at underlying or precipitating causes. That's always going to be our first thing that we do in any disease condition. See if we can identify them and manage the underlying cause. If the patient develops heart failure, we're going to correct it with medications as long as we can. And also, of course, lifestyle changes like a low sodium diet. That's going to be key because think about sodium and fluid retention. If these patients are having heart failure, that's going to be a huge teaching point and, education for your patient. These patients will be on an exercise rest regimen because they need exercise, but they also will need rest. And we're going to also try to control dysrhythmias. Medication therapy is going to be important, and it's going to vary by the type of cardiomyopathy. ACE inhibitors is our first line often, and this we know inhibits the conversion of angiotensin 1 to angiotensin 2, ultimately leading to vasodilation. In addition to this action, we also know that angiotensin 2 stimulates the release of aldosterone, which increases sodium and water retention and reabsorption in the kidneys. So ACE inhibitors block this aldosterone release too, which is great because it will decrease their fluid volume and also lower their blood pressure. Beta blockers, we know, work by blocking the effects of adrenaline. They help to slow down the heart rate, reduce the force of contraction, and ultimately lower BP, decreasing cardiac workload overall. Calcium channel blockers are important in types of cardiomyopathy because we know that they inhibit calcium flow into the cardiac and smooth muscle cells, the blood vessels. When this happens, when these smooth muscle cells in the arteries are relaxed, we see vasodilation, which is good because it can help reduce blood pressure and improve blood flow to the heart muscle. Calcium channel blockers also reduce the force of myocardial contraction, which can be helpful in certain types of cardiomyopathy. And calcium channel blockers, some of them like cardizem, diltiazem, verapamil, affect the AV node. So that will help slow down the heart rate. And that gives the ventricles more time to fill, particularly during diastole. So these meds are helpful for that. We always look at our DIG, especially in heart failure, and we know that DIG works to increase the force of or the strength rather, of our contraction. We're always monitoring our patients when we give DIG. Again, think of your symptoms of DIG toxicity, anorexia, nausea, vomiting, particularly visual changes. If a patient tells you they see halos around the lights, we are thinking DIG toxicity. So know your levels, know what you do for high DIG levels and low DIG levels, know your potassium levels too, because we know that low potassium or hypokalemia can precipitate DIG toxicity. So we're looking at our potassium levels, correcting our low potassium, so minding our values. And of course, check your heart rate before you give it. Diuretics, we think about furosemide or Lasix to decrease the volume overload they can have. And think about your potassium loss. Again, go back to if they're on DIG with a diuretic. Always checking potassium levels and correcting. And we know that Lasix and diuretics will lower RBP, so we have less volume on board. So we're checking all these things as we're giving this medication before we give it and as they're on this type of therapy. Spironolactone is another type of diuretic you'll see in cardiomyopathy. We know that this is a diuretic. It helps us drop our blood volume, which is good in these situations because they have extra volume. It's also an aldosterone antagonist. So similarly, then spironolactone blocks aldosterone, and therefore it promotes the excretion of sodium in water. So that's good because it decreases the workload on the heart. What else do we have here? Okay, so some patients may need antiplatelet therapy, like if they had a history of CAD, or if they have a history of AFib, we know that they may need an anticoagulant. Some other patients with cardiomyopathy may need different types of anticoagulants for different reasons, but they're generally the reasons that we're thinking about, and the cardiologist will, prescribe the medication based on their condition. Other management, these patients may need a pacemaker, particularly if they're bradycardic or have a heart block or a slow AFib. Heart failure patients often need pacemakers to help also to synchronize their ventricles, and that improves the efficiency of these weak hearts that they have. Again, think about your patient that has a less than 30% ejection fraction. They're at higher risk for lethal arrhythmias. So they will need an AICD or ICD, whichever way you want to term it. The A just stands for automatic. And then if these patients if they continue to progress and we can't get them any better with medical management and other therapies, they will be in line for a heart transplant. So this is a patient that gets a heart transplant this is an option when nothing else is working. So no medical, no surgical therapies are able to be effective for them. And there's a clip on here, it's about 4 minutes long, it's very good. It talks about how the transplant surgery works. So again, these are for patients that are end-stage heart disease. So during a heart transplant, the recipient's entire heart, including their coronary arteries, are removed, and they're replaced with the donor's heart and coronary arteries. So the recipient will get the arteries that are attached to the heart that they get. So keep that in mind. This is the list of things a patient has to qualify for a heart transplant. Not everyone gets on the heart transplant list. You have to meet a strict criteria. Often patients that are sick enough to get on the heart transplant list die on the transplant list because maybe they didn't get a heart in time, or they fall out of range for being able to be eligible because they're too sick for surgery. So view those. No need to memorize them, but just have an understanding of what we're dealing with when we see the criteria for the recipients. For heart transplants, the nursing care is going to be important for you to understand. You can see the picture here of the heart with all the suture lines where they attach the big vessels like the aorta and the pulmonary artery and things to the new person who's getting the heart. So these patients, if you haven't listened to the discussion about cardiac tamponade yet, these patients are at risk, and you'll understand why once you understand that patho better. These suture lines can leak. It's not very common anymore, but if they're not tightly adhered the way they should be, we'll see things like symptoms of cardiac tamponade because there's fluid in that pericardial space, and it can lead to this emergency. So for these patients, they'll have particular signs and symptoms. They'll have JVD, muffled heart sounds, and often hypotension. They'll be our big take-home signs and symptoms of cardiac tamponade in the presence of a heart transplant. Reason being is we usually know that patients with, cardiac tamponade chest pain. Well, the patients who have heart transplants, they are unique because the transplanted heart, although they get the coronary arteries and the heart from the donor, the recipient, their nerves are not attached to this new heart. So they consider this transplanted heart to be called denervated. So there's no nerves attached from that new heart to the body's autonomic nervous system. So that presents some challenges that we address and are very aware of when we're taking care of patients post-transplant and their whole life afterwards. For example, their pain response in the heart is often altered due to this denervation because they don't have nerves in their heart. So they may not sense chest pain. So we're looking for other symptoms of cardiac tamponade and other symptoms of things like MI. Their resting heart rate post-transplant is often higher than a normal person, generally 90 to 120. A normal heart, remember, is 60 to 100. But this happens because the vagus nerve, also part of the autonomic nervous system, is severed, and that usually helps us to slow down our heart rate. When we don't have it attached, we can't, these nerves don't regenerate, so we'll have these issues with heart rate being higher. So that's expected, and we see that. This can also lead to, over time, this can lead to an altered response to physiologic stress because their heart, the nerves aren't regulating that as well. And also they'll have an increased susceptibility to certain dysrhythmias like AFib for this reason. Over time, their heart rate may start to decrease slightly, but it's typically higher than the regular person's heart rate. This denervation process can also cause the patient to experience orthostatic hypotension. So when they get up, their blood pressure drops, they can be syncopal and things like that. So particularly post-op, as they're adjusting to the way that this works, we are being careful that they don't get out of bed quickly, and we're teaching them that. It's funny because years later, patients still have a hard time remembering, and they need reminders to get out of bed slowly and rise slowly because they get this orthostatic hypotension. It's just it's a habit. It's habitual to just be impulsive and get out of bed and want to do what you want to do. So it's a re-education all the time for these patients often. We think about patients are on immune suppressants lifelong. So we're thinking about their risk for infection. We're teaching them signs and symptoms of infection, how to prevent infection and recognize infection. We also think about stroke risk after transplant. Patients, they're at risk for AFib because of this new heart that I just talked about. These patients also have a history of CAD. So go back to your risk factors for CAD, things like diabetes, hypertension, high cholesterol. These patients, although they have new coronary arteries, they still have these risks for developing new coronary artery disease because they have the risk factors for this coronary plaque development, like the diabetes, hypertension, high cholesterol. So, and then we think too, we're giving them immune suppressants, so steroids. And these steroids, of course, we know can exacerbate blood sugar issues, not good for patients with diabetes, harder to manage the condition, so we're careful about that. Patients that are on the steroids, they have a history of hypertension. We know that steroids increase our overall fluid volume. So that can increase our blood pressure. So we're thinking about what kind of medications or what kind of treatments and therapies for hypertension, keep it under control so we don't damage these new coronary arteries. And then, of course, we know steroids increase cholesterol. Many of these patients with CAD have cholesterol issues. So again, tightly monitoring and watching their diet and their intake and their medications may need to be adjusted and labs frequently. These patients are going to have to take these immunosuppressants for the rest of their life. We know that this is something we teach them and explain to them before they have it, and before storing, they have to take their medications so they don't have rejection. Other medications we think about, again, go back to the fact that we are not attached to our autonomic nervous system anymore, like the heart is not attached. If a patient becomes bradycardic, for example, we often usually, we give atropine. Well, think about your mechanism of action of atropine. We know that atropine blocks the effects of the parasympathetic nervous system on the heart. and that usually increases our heart rate. But now this parasympathetic nervous system isn't connected to the transplanted heart. So atropine is not going to work the same. It's not going to be effective. It's not going to get the job done. And then often, if atropine doesn't work for a bradycardic patient, sometimes we can give a dopamine drip. Not the case post-heart transplant, because dopamine, go back to its action. It works on the sympathetic nervous system, again, part of the autonomic nervous system. So it's not going to be effective in our post-transplant patients. So basically, look at all of your meds before we give them and think about how they work. And if we don't have a nervous system, can we use that medication? Or is it, we're just wasting our time? Often bradycardic patients, just for your own information, if they become bradycardic, we're thinking transcutaneous pacer if they don't have a pacemaker in already, because a lot of the medications work on the nervous system, the autonomic nervous system. So thinking of all of these things for our patients that have had, a transplant at any time, because some medications won't work for them. As far as transplant rejection, of course, we're teaching hand washing, avoid crowds, the types of foods they can eat, no raw foods, things like that. And clinical manifestations, important to recognize the signs and symptoms of heart rejection. It's often subtle. Like, we don't see that they'll have abrupt signs and symptoms. Patients that have had a heart transplant will have to get subendocardial biopsies pretty frequently to see if they are rejecting. So that's one way to tell. Some symptoms we may see: shortness of breath, fatigue, fluid retention, fever, waking, swelling, hypotension, and then they have a harder time exercising. They have reduced exercise tolerance. So all of these things that we're teaching them, if they haven't, look at your baselines. Always see what your baseline is and see the trends. Are we seeing a change in what they usually do? If so, it needs to be reported, because they could be rejecting, and other things can be happening. So when there's a change, we report the change. Always get a good baseline assessment and have them understand their symptoms and how they their daily life. And if there are changes to what they're experiencing, they need to report that. So that ends our discussion. If you have any questions, please post to the discussion board and contact me, reach out. Thank you.